Hari ini terima kasih sudah datang untuk acara webinar Pediatric Oncology kita hari ini yang diselenggarakan oleh Pelayanan Kanker Terpadu RSUPN Dr. Cipto Mangunkusumo Jakarta berkolaborasi dengan Perhimpunan Dokter Spesialis Onkologi Radiasi Indonesia. Di sini kita sudah terregistrasi, ada lebih dari 400 peserta, termasuk 30 diantaranya dari peserta internasional. So good afternoon for everyone who have already joined this webinar. Welcome to our pediatric webinar hosted by the Comprehensive Cancer Care Dr. Cipto Mangunkusumo Jakarta in collaboration with the Indonesian Radiation Oncology Society, Iros. Thank you for coming to this webinar this afternoon. My name is Giselvania, or I used to be called as Giselle. I will be the host moderator for this webinar this afternoon. So this webinar will have several speakers, including the introduction lecture will be brought by Prof. Soehartati Gondhowiardjo, Iros President, and also the coordinator for the Comprehensive Cancer Care Clinic in Cipto Hospital. And also we have 3 other speakers, Mr. Gampo Dorji, National Non-Communicated Disease Officer from WHO, Southeast Asian Regional Office SEARO, who will brought the topic about global directions on pediatric cancer. And we will also have Dr. Endang Windiastuti, Senior Pediatric Oncologist from Dr. Cipto Mangunkusumo Hospital, with her lectures overview childhood cancer burden and challenges in Indonesia. Last but not least, we will have Professor Siddharta Laskar, radiation oncologist from Tata Memorial Hospital, India. His lecture will be about the role of radiation oncology in pediatric cancer, global strategy, basics of pediatric radiation oncology, and setting up pediatric radiation oncology program. Before we start the program, please welcome our President Director of Dr. Cipto Mangunkusumo Hospital, Dr. Listina Liastuti, to open this webinar. For Dr. Listina, please, the time is yours.
Thank you, Dr. Giselle. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon for everyone. Our honorable guests and distinguished speakers, Professor Soehartati Gondhowiardjo, the Coordinator of Integrated Cancer Services, Dr. Gampo Dorji, Technical Officer for Non-Communicable Disease, WHO Southeast Asia Regional Office, Professor Siddharta Laskar, Professor of Radiation Oncology, Tata Memorial Hospital, Mumbai, India, Dr. Endang Windiastuti, the Pediatric Oncologist at Cipto Mangunkusumo Hospital, and also Dr. Angela Giselvania. I welcome you all virtually to our hospital, our second home. First of all, let's praise Allah Subhanahu wa Ta'ala for His mercy and blessings. Thus, we are able to attend this incredible webinar. On behalf of RSCM directors, I appreciate the Integrated Cancer Services Unit and Indonesian Radiation Oncology Society for holding this event amidst the COVID-19 pandemics. For all speakers, we are truly grateful for having you here. Many studies have shown that COVID-19 has disproportionately threatened patients with immunocompromised status. 60 to 70% of patients with cancer, whether they are adults or children, are at higher risk of getting infected or to develop severe symptoms than the others. In our report, 31% of inpatients suspected of or confirmed with COVID-19 are children. 48 children, or 32% of all, have cancer, from AML, ALL to cynodental tumors. Moreover, 63% of our pediatric inpatients who died due to COVID-19 have tumors or cancers. This heartbreaking statistic should be transformed into actions to improve our quality care. To move this needle, the directors and management have discussed the issue with the Radiation Oncology Department. The service will remain open as such. We will not limit the quota of services. We have been strengthening the health protocol status and making some adjustments, including hypofractionation, verification arrangement, disinfection, and other preventive measures. Nevertheless, we should not be quickly satisfied with this current effort and must reevaluate the processes. Are these strategies have aligned with global standards? What are the other challenges we might face? How to encourage parents to bring their kids to the hospital to get cured? I hope this webinar is beneficial to everyone. I encourage you all to engage with these distinguished speakers. Do not hesitate to ask questions. I wish you all an enjoyable webinar. Thank you, everyone. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Dr. Listina. Now we will have Prof. Soehartati Gondhowiardjo, coordinator of the RSJM Integrated Cancer Center, and also the President Iros, to give the introduction about the importance and value for pediatric cancer services. For Professor Soehartati, please, the time is yours.
Thank you very much, Dr. Giselle. Moment, I have to look for, yes. Yeah, okay. Thank you very much, Dr. Giselle. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. First of all, I would like to thank the director of the hospital, Ibu Liz, for your always support to us, to oncology group in our hospital, as well as I would like to thank to our friends from abroad for your willingness to be here with us. Even it is through the moment. I have to. Moment. I have some error here. Moment. Yes. Yeah. So I would like to thank to Mr. Gampo from the WHO, as well as to Professor Siddharta from the Tata Memorial Hospital, Mumbai. And also I would like to thank, of course, to my senior, Dr. Endang, the very smart and very pediatrician who work a lot with the pediatric cancer. And I would like to say hello to all the participants. And I know in the participants, there are some friends from Myanmar, Professor A.A., the president of the Myanmar Radiation Oncology Society. And we have also Professor Ivan Tam from Singapore. And maybe Professor Miriam is also coming from Philippines. And we have some participants from Philippines, from Myanmar, as well as from Singapore. And I would like also to thank to all participants, our participants, pediatricians, radiation oncologists, and other disciplines from anywhere in Indonesia. I would like to just open a bit about what is the data of the pediatric cancer right now. We know that cancer is the world's most deadly disease, and we know that there will be increase significantly the number both the mortality as well as the new cases in the world. And the unfortunate situation is that 70% of cancer will occur in low and middle income countries, included Indonesia. This is the data, the cancer patient in Asia. And we can see here that the difference between the mortality and morbidity, it seems that the mortality rate in Indonesia is a bit higher compared with the, not a bit, but higher compared with in Europe, America, and as well as in Oceania, is a bit lower than in Africa. From these both two picture, we can get that information. And the childhood cancer account less than 1% in the total case in high income countries, but about 4% in low and middle income countries. If we talk about the childhood cancer, we know that it's the first cause of death of cancer in children, and 43% of children are diagnosed with cancer, as well as 40,000 kids are in cancer treatment each year, and 1 out of 8 children with cancer will not survive. This is the data of 10 pediatric cancer in the world. We know that leukemia is still the highest, and followed by brain, non-Hodgkin, Hodgkin lymphoma, etc. And if we compare with the data in Indonesia, we can see that the leukemia is the same, the highest number, and also brain, the number 2, and the non-Hodgkin lymphoma. But then the difference in our data is the next is nasopharynx and the colorectal cancer. So there are some difference between the rank of the incidence of cancer, pediatric cancer in globally and compared with in our countries. But it might be underestimate the true incidence, since children with cancer might not be diagnosed due to the lack of awareness and lack of resources. Some data show that the number of pediatric cancer in low and middle income countries is getting higher with the higher mortality, but in high income countries is going down, decreasing with the low prevalence as well as the low mortality. So it is stated that 80% of children with cancer live in the low and middle income countries. And also we can see here the blue one is the number of cured patients in high income countries achieve until 80%, but in low and middle income countries is in the other way is 20%. It is due to, again, awareness, access. It makes the late diagnostic, poor result, as well as the high toxicity. We know that the cancer treatment generally is a multimodality treatment, consists of surgery, chemotherapy, and radiotherapy. And this show you the childhood cancer in our hospital. Our hospital is the top referral hospital in Indonesia, the Cipto Mangunkusumo Hospital. With the data from 2010 and until 2015, it seems that it's a bit different. Leukemia is still, but the second is a retinoblastoma, and then followed by lymphoma is maybe the same. But then come neuroblastoma, osteosarcoma, rhabdomyosarcoma, and nasopharyngeal cancer. This show you the blue is the number of total childhood cancer in our hospital. And the orange is the pediatric cancer patient who are sent to our department, to radiotherapy department for the treatment with the irradiation. So 25% of pediatric cancer in our hospital are sent to our department for the radiotherapy. And what is that? That's the 10 highest number of patients who are sent to our department for irradiation. The highest is the brain, and then followed by eyes, nexa, nasopharynx, bone, and etc. And this, if we see the center, all of our radiotherapy center in Indonesia, we can see here that from all patients treated with irradiation in all those centers, 2.3% from all those patients, cancer patients are irradiated are pediatric cancer. So it is in line with the information in the previously that in general, the pediatric cancer is among 1 to 4% from all cancer patients globally. So in our case is 2.3% is about. And this is our preparedness for the radiotherapy all over Indonesia. We have 58 centers with 94 radiotherapy machines is ready to give a good service for the pediatric cancer patient. But we are not happy with this. It is not yet enough for our population in our country. So we are still do advocacy with the private hospital, local government, national government, as well as the investor. So now, at the end of this year, or maybe first semester of next year, the number of radiotherapy in our countries will increase, become 67 centers with 103 radiotherapy machines. Is quite significantly good increase. And you can see here that the non-government, the private sector increase is quite significantly high increase. This is just to show you 14 national cancer referral hospital also ready to help the pediatric cancer patient. And this slide show you the distribution of all the oncologists in our countries. The latest is the pediatric oncologists. There is 58 pediatric oncologists within our countries. Maybe they will be correct by Dr. Endang later. That's from the data that we have. But as well as other oncologists in our countries, the distribution is not really equal within the province. We can see that's the highest number is in our center in Jakarta. So the summary of the cancer problem is Indonesia is of course the limited public knowledge and limited oncology resources, limited access, and limited hospice home care. Now a bit I would like to talk about the COVID in Indonesia in relation with the pediatric oncologists. That's the number. It is from the 3 or 4 days ago. The number of COVID incidents in our countries with the number of mortality rate. And this show you the cancer is that's the data from our country. That cancer is one of the comorbid. You can see that cancer is there as one of the comorbid, and also from the diagnosis as well for the mortality. And we can see here the number around 8% from the cases are pediatric childhood patient, and the mortality is around 2%. So it seems that the mortality rate of the COVID patient in pediatric is lower than in the adult patients. But all this data only come from 1.5% because the other patient has no complete data or no comorbids. As we know, it's already mentioned by our director of the hospital that 60 to 70% of cancer patient has a immunocompromise. That means it's more easier to get the COVID corona infection or COVID disease. And if they get a COVID, this level of severity will be increased almost 5 times. That's in adult situation. How is in kids? There is some literature mentioned that it's also happened in pediatric, that there are some comorbid condition will make easier the kids to get the COVID. And then also there are some higher risk for the severe COVID, but it is mentioned here that for the immunocompetent pediatric patient with COVID experience less severe disease than adult. So that's a good thing. And other things is anyhow, the pediatric cancer, the cancer remain the primary disease-related cause of the mortality in children. So what is the conclusion is that we must not lose focus on the need to continue effort in pediatric cancer service and research, even in the COVID pandemic situation. So challenges for the pediatric oncology in the COVID-19 pandemic is difficulty in hospital consultation, increased risk of coronavirus infection, treatment delay, shortage of blood component, and social impact. The last issue that I would like to bring to you is the physician to override parents' medical decisions making for their child. When should doctor agree to parental demand for suboptimal medical treatment, and where are the boundaries? There is one paper, good paper, family refusal of chemotherapy for pediatric cancer patient. It is mentioned that the refusal of the therapy is ethically acceptable for competent adult. But how is it in children? Children with moderate or good expected cure rate as unacceptable, but were more accepting for a refusal with the poor prognostic. So it is still under the discussion. just want to see that a kind of we have to have an algorithm needs to be established in every countries by the Ministry of Health, endorsed by the medical societies related, and further knowledge and implemented in the hospital, because there is a big issue about that situation. The last, what is our dream? Our dream is to have a comprehensive cancer care center, including pediatric, consists of diagnostics, psychiatrist, palliative oncology nurse, case manager, and oncologist, and ethic consultation under the national planning and policy advocacy with the cancer, with the centralized cancer registry, district health system, research community, etc. And the important thing is the public donation and charity house and survival community under the Universal Health Conference with the standard guidelines and integrated referral system with the global strategy supports. We know that we are still have a big gap, but they said that there is no mountain too high to climb, even it is the Mount Everest. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Salam. Thank you, Prof. Tati, for your interesting lecture. If anybody have questions for Prof. Tati, please type your answers in the Q&A feature, and then it will be answers directly or answered by the speakers at the end of the sessions. And now we will move to the next sessions. The next speaker is Dr. Gampo Dorji. He is technical officers for the NCDs at the WHO Southeast Asia Regional Office. He is now based in New Delhi, India. So now please welcome Dr. Gampo Dorji.
All right. Good day, everyone. I'm just sharing my slides. I'm not sure whether, please confirm you are able to see it, first of all. Can you see it?
Yes. Good.
All right. Okay, good. Great. Again, good day, everyone. I want to really thank Dr. Elias, the director of Cipto Hospital, Professor Tati, and her wonderful team. And I am taken again back to my memories when I visited your team in Indonesia, Jakarta last year, and had a lot of hospitality there. So I really thank on behalf of WHO. I'm joining in from New Delhi Regional Office of the World Health Organization, and I have been assigned to briefly discuss about the global direction in childhood cancer. And I'll be touching a little bit about what WHO is planning and what has been the global momentum in the area of childhood cancer. I want to, again, sort of begin with where Professor Tati left, that no mountain is too high to climb. Even if it is Mount Everest, we will get over it. All right, with this, I think it's such a powerful words. And in this difficult time when we are all the countries are experiencing difficulties with COVID, I guess, is such a great leadership and opportunity and encouragement that the experts, professional bodies led by Professor Tati and others are organizing this, and we thank you for your invitation. So I have a couple of slides, and basically some of this will be a repetition on the figures, but I will not dwell on this. I want to thank my colleagues, Dr. Andrew Ilbaway from WHO Geneva, and he's my focal point at the headquarters in WHO in Geneva, my wonderful friend, and Dr. Vishnu Ratgiri, who is on my team as a consultant for pediatric cancer. He's not, I think, not able to join because of other commitments, or maybe he's joining later, but they have helped me prepare for this presentation. I thank them for their support. So let's get back to, I hope you are able to hear, and if there's a disruption in the noise, please do let me know. So understanding the context, again, at the global level, all of us know that the momentum in NCDs really at a global level came from 2011 UN General assembly high-level meeting on NCDs, and it has become a very integral part of the UN response, and WHO included. But in the areas of cancer, we had a lot of global stakeholder meetings. But in 2017, the World Health Assembly endorsed a resolution to strengthen cancer prevention and control in an integrated approach. And the countries have agreed to strengthen cancer control responses in their countries. There are also other global and regional commitments in the area of cancer control and in the era of SDGs, as you know. And cancer control is an important part of the Sustainable Development Goal agenda, including NCDs. So the global dialogue on NCDs, on childhood cancer was reinvigorated in 2018 by the World Health Organization in Geneva. And maybe it's worth recalling that in September 2018, WHO launched or announced the launch of WHO Global Initiative for Childhood Cancer after the high-level meeting on NCDs in 2018. So I'll be discussing what we call the WHO GICC, WHO Global Initiative for Childhood Cancer in this talk, and then address some of the things that we will be doing at the grassroots level. So Professor Tati mentioned about this information, and I don't want to repeat much, but I think it's still good to remind ourselves that we have nearly 500,000 children getting diagnosed for cancer, and most of these are in low and middle income countries. And we have already, Professor Tati alluded to the global inequities in childhood cancer, where high income countries, the survival rate is over 80%, and in low middle income countries, 5-year survival rate among children with cancer is less than 20% in some settings. There are many reasons for this, and some of the reasons for inequalities have been already highlighted. But what we note, again, this is all in the literature, is that in low middle income countries, some of the prominent problems are no diagnosis in the first place. By this we mean that children living with cancer even don't get a diagnosis. They are not actually able to seek care. So forget about other treatment and care. This is quite a huge proportion. And then when they're sick, there may be misdiagnosis and refusal to treatment, abandonment. And of course, once put on treatment, again, children do experience toxic consequences because of the comorbid conditions, nutrition, infection, and all this. And finally, the cure is very low in low middle income countries. So we will go. So coming back to what I mentioned, the WHO GICC, Global Initiative on Childhood Cancer. What is that and why? So again, the aim is big and ambitious, and perhaps it is doable, that by 2030, as a part of the broader Sustainable Development Agenda, the global initiative aims to achieve at least 60% of global survival rate for childhood cancer. And recalling that in high-income countries, it is over 80%. And we are still, many of the countries are going under 20%. Of course, there are countries little doing better and leaving no one behind. And each year, over these 10 years, hopefully through this initiative, we'll be able to save about 1 million additional children lives. Okay, the focus of the GICC, of course, is overall cancer for sure. But what they also identified is why not address the most common cancers in children, because they are highly curable with proven therapies, and they represent almost 50 to 60% of the childhood cancers. And these are 5-6 top cancers that will be paid attention through GICC. But that doesn't mean that other cancers are not important. It's a part of the whole systems approach. And we have seen through Prof. Tati's presentation that some of this actually ranked higher even in Indonesia. So coming back to some of these GICC goals, I did mention, but I want to allude you to something called how do we make it happen? WHO is coming up with something called the Cure All Technical Package. And if some of you are wondering, what is that again? It's basically a comprehensive set of approaches that will be used to implement the global uh, uh, childhood cancer initiative. And Cure All actually represents the acronym C for Centers for Excellence, and which will include human infrastructure and others, universal health coverage, which Professor Tati mentioned. It's about giving that package of service delivery, resource appropriate regimes, not that we have you have your own resource appropriate regimes and protocols adapted medicine that are actually supported technologies, medicines, and finally having a constant improvement to evaluate your services, information system and all. And childhood cancer prevention and treatment and management will need advocacy linked to financing and policy. So this is a holistic approach, and Cure All is a technical package that is under development by WHO headquarters, and we are hoping that it will be released in the next 3 months as per my latest communication. And the Cure All has all these components. There are a lot of things about financing, on the treatment regimes, then how to develop national cancer control strategy, even the economic analysis, and so many tools that countries can use to improve cancer control in general, and especially also in the childhood cancer, specific to childhood cancer. So there are tools coming up to guide and help countries on that. And this will be finalized. They are working very hard, and this will be available soon, within the next, say, 90 days. So the GICC initiatives I mentioned, there are issues, so solutions at local levels, and all this we will not talk, but these slides will be made available. I want to jump then, coming back to what in our region, because WHO has 6-7 regions, and we are called the Southeast Asia region, where Indonesia and other countries are included. And WHO regional office, in consultation with the countries, we are working on implementing the global initiative into a regional approach. And we are calling this a SEARO initiative, and we are establishing, if you recall the Cure All, we have to set up networks, practice excellence institutions. So we are establishing a network of practice institutions among the region. And you will, and by 2030, we hope that we will be able to align to these goals that is there in the GICC. I will talk more. What are some of the network activities? So we are actually, WHO is bringing the countries in the region to build a network for childhood cancer among the experts, so that they can share, learn, and strengthen childhood cancer work in the region, and to influence the ministries of health to take evidence-based actions, to support the ministries of health to take actions, and others. So there are a lot of things that is actually included in this network. We have at the moment, in the first year, we have just begun this year, and we have 6 countries included out of our 11 countries for the first year: Indonesia, Myanmar, India, Sri Lanka, Nepal, and Thailand. The institutions have been identified. We have requested the governments to nominate the institutions. It is not limited to few. We can always include more institutions if they want, but we have about 11 institutions as of now from the 6 countries. And Cipto is one of our leaders, and we will soon begin the greater engagement process. And we will do all these regular meetings. We may even think of trainings, workshops, maybe if COVID and other things become better. Yes, all these field visits and learning and sharing on a routine basis. And the COVID-19 strategies, again, we learned from Professor Tati how you are actually adapting, from even from Dr. Luis, how you are adapting. So we will have in this forum to engage more, learn from each other. And the first network meeting is now planned for 21st August. We are very excited about that. Maybe if some participants are wondering what are the details, we are hoping that we will come up with concrete details and actions from there, but this will give a very good platform for everyone with the same mind vision to come together and as countries to learn from each other. So we are excited, and I hope others are too. So I did mention about this, and we have 11 countries in the region. So next year we want to include some of the next 5 countries like Bangladesh, Bhutan, Timor-Leste, and other countries, Maldives, North Korea. So this is it, so we will have institutional teams, childhood cancer champions. We are also inviting some of the social community-based organizations to join the network as a part of the community response, in addition to Ministry of Health officials and WHO country officers. And finally, this is my second last slide, I guess. In Indonesia, we have 3 institutions identified: Indonesian Pediatrician Associations, Darmais Cancer Hospital, and Dr. Cipto Hospital. So we have already 3 designated institutions who will join the network, and Ministry of Health, WHO country office. And we will join in this journey with other countries, and we will learn a lot from it, and hopefully we will do more than what you are already doing to improve the quality of care, increase the coverage, or even relook at some of the services that you have to improve, and finally make difference so that we are able to save more lives of children who are dying from amenable cancers. Finally, there are actually countries that they say, and this I just highlight because WHO headquarters has noted that Peru is one of the examples in the Central Americas, where they started very low, but the Ministry of Health organized these groups through this network, what we call the Global Initiative for Childhood Cancer. The Ministry of Health took a strong leadership. They put the working groups, professional bodies together. They formulated the cancer plan, including childhood cancer. They mobilized funds, and finally, the program is running very strong, also with partnership of WHO and many other partners. And this is possible. And we are hoping that such movement will come very quickly. And for the first time, WHO is also taking this initiative to work with countries, I guess. Cancer control was not, even though it is a core response of WHO, it was still weak in the past because of funding and many other areas. And we hope that we should be able to do more work in cancer control, and especially in childhood cancer. And we hope to learn from Indonesia's leadership and professional expertise. So with this, I want to thank you.
Thank you, Dr. Gampo Dorji. Thank you for your excellent talk, and thank you for sharing with us the global direction on pediatric cancer. Again, for all participants, for reminder, if you have any questions, please use the Q&A features on the Zoom applications, and it will be answered later directly or live by the speakers. We will now move forward to our next speaker. Our next speaker is Dr. Endang Windiastuti, who currently works as senior consultant pediatricians in the divisions of hematology and oncology in pediatric department in Dr. Cipto Mangunkusumo Hospital. She finished her master in pediatric medicine in University of Melbourne, Australia, and she also have her training on thrombosis and hemostasis in Liverpool, UK. And without no doubt, she is a very well-known pediatrician oncologist in Indonesia. She will be speaking to us on the overview of childhood cancer burden and challenges in Indonesia. For Dr. Endang, please, the floor is yours.
Thank you. I'd like to share my, hold on. Okay. Okay. My slide is clear?
Yes.
Yes, okay, thank you. Okay. Good afternoon, everybody. First, I'd like to say thank you to Prof. Tata to invite me to join this meeting. This is about the burden and challenges childhood cancer in Indonesia. This is my outline. Then there are many reasons why childhood cancer should be a global child health priority. I cited from the CCI. Childhood cancer statistics do not tell the whole story, and childhood cancer does not have border. And because a childhood cancer is curable, but there is still a significant inequity and disparity in the survival rate across country and continent. And because 1 death of the children is too many, and we know that the children is our future, and they deserve the chance to live to full. And by access to the better care, we can help stop the dying. And the other thing important, access to the best possible care of our children with cancer is their human right, not just a privilege. So this is our country. We have more than 17,000 islands with a population, I think, more than 250 million. This is a new one, Prof. Tati, but still same, I think, the pattern. The acute leukemia, retinoblastoma, and the lymphoma still the major 1, 2, and 3. So I want to show this by the age. We can see the leukemia almost occur in almost group of the age. It's compared retinoblastoma almost in the child below 5 years old, and the osteosarcoma, we can see the green and yellow one is 10 years until 18 years. So globally, the new cancer will increase from 10 million in 2000 to 15 million in 2020, and 70% are expected in low-middle country, like Prof. Tati mentioned, and also Dr. Gampo. Delay in accurate diagnosis, the lack of awareness, lack access and ability to deliver potentially curative treatment, the abandonment of the treatment, support of pediatric oncology program may not take priority. And several health indicators like number of pediatric oncologists, nurses, and annual government is still, I think the expenditure is still suboptimal. Cancer registry is also non-existent. We only have the hospital registry, but not in the community. So most of the patients still underdiagnosed and under registration, I think. Which table show the access to the hospital. I take it from Riskeda, is reached by the Ministry of Health. You can see the green one is the very difficult to access to the hospital, and the gray one is the easy one. We can see in our capital city, Jakarta, we have still around 50% that the people with childhood cancer is difficult to catch the hospital. This also shows the cancer prevalence diagnosed by the doctor. We can see in the age below, this is a 24, it's a very small number of children diagnosed by the doctor. It means that a lot of children with the cancer do not come to the doctors. It is a hematology oncologist. So this is a number, I think, the new one. We have 61 pediatric oncologist consultant, but we can see in not all of the island have, like Papua in the east one, and Maluku, and the big island like Borneo, Kalimantan, they only have 2 pediatric oncologists. So it's still not enough to care all the cancer, childhood cancer. So this is, I think, the patient problem or the family problem faced. Start from the nutrition status, the education, the knowledge, the health center of childhood cancer care, and the transportation, the communication, infection, and social economy. How about the pediatrician? I think now we overburden pediatric oncologists. I feel that there's a very significant increasing in a number of patients since BPJS 2014, it must not be taken, since the government launched the insurance for all people. So become the pediatric oncologist is a very hard work for that. The problem is not only the pediatric oncologist, not the patient, but also the financial coverage, childhood cancer treatment, diagnostic facilities, the treatment, the chemotherapy medication, and pediatric cancer unit. So in our country, every teaching hospital in the capital of the province, we have the Center of Pediatric Childhood Unit. Another thing that lack of training nurses, clinicians, pathologists, radiology surgeon, and other staff who also handle the childhood cancer, and also the establishment of the supportive care. We can see here, this, I think this is old data, but we can see that in 2012, Indonesia, the incidence leukemia is around 3.4, but the mortality, I think the 2.3, something like that. So still, the mortality is high in our country. So how many children are diagnosed with and survive in the worldwide? As mentioned before, like Prof. Tata and also Dr. Gampo mentioned, in many high-income countries, 5 years survival rate more than 80%. And in the low and middle country, the global survival is substantially worse. And now our country are going rapid epidemiology transition, I think, shifting from the infection to non-communicable disease like renal disease, heart disease, and also diabetes is increasing. So to improve the outcome, I think the accurate appraisal of the global cancer burden in children is necessary. This also already present, I think, from Dr. Gampo, but I want to show the incidence and the mortality in Asia and also in North America. In North America, the blue one is the incidence, 182 per million childhood cancer, and the mortality is around 15%. But see Asia, the mortality, I think, almost 50% more death childhood in cancer. So this is a very interesting cross-sectional study from from Mesir in Cairo. There are 188 participants of the children. So they try to see what is the cause of delayed diagnosis and treatment. You can see here from the onset treatment, the initial healthcare contact, assessment by oncologist, final diagnosis, and start the treatment. The median delay was 37 days. Not only because of the parent, the median delay only 3 days, but we can see the physician delay, like initial contact from the healthcare in the assessment by the oncologist. This is the most 28 days. And then the whole treatment, the treatment is maybe around 3 or 4 days, but the total median delay is 37 days. Maybe this is the same with our country, I think, in Egypt. So this is also important, I think. The nearly half of global childhood cancer cases go underdiagnosed. Almost 3 million cases cancer will have been missed between 2000 and 2030, mostly in South Asia and Sub-Saharan Africa. We can see that from North America, 3% underdiagnosed from 10,900 cases. Asia, South Asia, 49% undiagnosed from 137,000 cases, and 43% predicted undiagnosed in the worldwide from 6,700,000 cases. So this figure shows the association between the social demographic index and childhood cancer incidence rate and mortality. We can see by the increasing social demographic index, the mortality decrease, even the incidence is increased. How about Asia? Indonesia is Southeast Asia. In circle, the red dot. We can see we are in the middle. We're still in the middle. So I think we hope that the incident, no problem high, but the mortality it should be decreased. So the global future children strategy in low middle income country, it should be raise the awareness of the cancer signs and symptoms amongst the public health and also the worker to reduce the miss or late diagnosis and also create the essential supportive care resources and facilities before starting to treat a patient. It should be established the supportive care standardization of palliative and financial coverage for the treatment and also accreditation of childhood cancer center like infrastructure, the patient volume and the policy implementation. And the cancer risk disease still have an important role, I think. So develop the national standard care and national treatment protocol. Indonesia have already have the acute leukemia protocol national for lymphoblastic, and for the myeloblastic, we have a national treatment protocol, the same for all the hospital. We're still going on for the retinoblastoma because retinoblastoma is the second most cancer in the childhood. So the challenges like Dr. Gampo and Dr. Prof. Tata mentioned, late presentation, advanced disease they come, ignore, accessible to the hospital, pathologists and other cancer specialists are very few, and it's very few dedicated to childhood cancer. The lack of facility for curative diagnosis, then the treatment problem. Another problem is about the follow-up. A lot of patients with the loss of follow-up, like after the primary surgery, usually they don't come, they think about the finish, and chemotherapy is very hard for the child. The survival, we all try to collect now. We have a group of the survivor now. We try to find and to see the long-term effect and others. So we still work on that. So the goal to managing good childhood cancer in developing country, I think we must increase the proportion of children have access quality and also the treatment. Like Dr. Gampo also mentioned, we have to increase the proportion. So how about this strategy in the living in the developing country? Establishment of the Pediatric Cancer Unit, I think is not enough now in our country. Raising the awareness again in the society, so the patient would present early, therefore they will have a benefit from whatever available of the treatment. Training of the cancer care specialists, all personnel from nursing staff and other auxiliary staff. And number 4, I think it's important, there is an acute shortage of trained oncologists. Now we have a consultant education for 2 years, official in the university. But I think we have to need acute shortage trained oncologists. And important thing, we have also not only the oncologists, the team in the hospital, specialists from other department unit, other staff involved, drug administration, also palliative and administration staff. So the trained pediatric oncologists can't work alone without the team. Very important there. And the establishment of the standard protocol for all major. So we already have the acute leukemia and we will work on the retinoblastoma for the next target. And also the supportive care, palliative care, and drug pricing, and is important, the availability. It is very important in the improve the care of childhood cancer. Collaboration, of course, international organization, association is a success for any national cancer program. So this is remember the slide before, the research from the Cairo. So they have a conclusion to shorten the delay, diagnostic delay, continuing the medical education for the healthcare provider, and it should be encouraged to seek the medical advice, then enhance the healthcare system to minimize the time of referral to the hospital. And then give priority to those with suspected cancer by the facilitating the referral. And of course, improve the diagnostic facilities. So this is a stepwise process in the development for the develop the pediatric cancer program, level 1, 2, 3, and 4. You can see the level 1 is early diagnosis, public awareness, education, and basic treatment and the palliative care. Palliative care starts from the level 1, 2, 3, I think 4. The level 2, we can see the curable with the infrastructure, improve the diagnosis and maximize the screening. The third, multidiscipline is also important, advanced technology. And finally, we have national or regional center of excellence. It is our dream. So by this fourth level, I think the survival of the cancer in children will increase, and also the research it will be increased too. So this is a very also interesting how to improve the pediatric cancer care, top-down and bottom-up. We can see top-down government and international organization activities, and bottom-up grassroots non-governmental organization activities is involved. From the first time, the suspicious of the cancer, primary care, clinical diagnosis until the treatment. So ideally, top-down and bottom-up effort should be coordinated and integrated to achieve the maximum. We have to communicate each other because the government or pediatric oncologists can't do anything without all the participants of the organization, non-government activities, and also the international and government international organization. I think this is my slide, last slide. So the summary, cancer in children and adolescents are fundamentally different from adults. Cancer in childhood is curable with cure rate up to 70%. Many children die from it because most of them do not have a good access to quality of management. So the aim of treatment strategy to increase the number, to increase the proportion of childhood cancer to have access to specialists and the treatment. And another, the last one is important too, the local and regional networking that should be supported to build the capacity. I think this is my last slide. Thank you very much.
Thank you, Dr. Endang, for your excellent talk. Again, for all participants, for reminder, if you have any questions, please write your questions in the Q&A feature, and your answer will be answered later. Untuk para peserta, kembali diingatkan bila ingin bertanya, dapat bertanya baik dalam bahasa Indonesia atau bahasa Inggris di kolom Q&A yang akan dijawab kemudian. Next, our third speaker is Prof. Siddharta Laskar, who will be cover 3 topics. The first topic is about the role of radiation oncology in pediatric cancer global strategy. And second topic, basics of pediatric radiation oncology. And also last is about the setting up pediatric radiation oncology program. To Professor Siddharta Laskar. Prof. Siddharta Laskar is Professor of Radiation Oncology in Tata Memorial Hospital, Mumbai, India. His areas of specialties include childhood malignancies, hematological malignancies, and bone and soft tissue malignancies. His special interests include high precision radiation therapy, brachytherapy, and also total body irradiations for bone marrow transplantations. To Prof. Siddharta, please, time is yours. Thank you.
Thank you, Gisel. Thank you very much. I hope my slides are visible.
Yes, it is visible.
Yes.
Yes, that's great. Okay, so thank you very much. It's always a pleasure to join this wonderful group. I always feel at home with this group. Thank you, Professor Tati, for organizing this. Professor Endang, it was nice listening to you. Dr. Tees, and my friends Gisel, Mayang, thanks for organizing. Dr. Gampo, it was nice listening to the overview and the perspective of WHO and the work that WHO is doing towards improving the delivery of pediatric cancer care in Southeast Asia and the Asian region. So the task given to me has three things. One is to give you basics about pediatric radiation oncology. Number two, to give you a global perspective of pediatric radiation oncology. And number three is how to develop a pediatric radiation oncology facility. But I will make it short because my time is 20 minutes and I can actually speak for 1 hour for each of them. But so as we go ahead, coming back to some of the statistics, we looked at the statistics and we know that the numbers of children that we see in our region, that is Asia and Southeast Asia, ranges around 100 to 130 per million children. And it is pretty similar, or actually slightly less than what you see in the West. This distribution of 100 to 120 is similar in the age group of less than 14 years to 15 to 19 years. So the proportions of children developing cancers remains pretty similar in both these age group ranges. Now, this is important to remember because many of the treatments that we do and the outcomes and the implications in terms of long-term toxicity is dependent on the ages. The other important thing that we need to look at is, as we go to a younger age of 0 to 4 years or less than 10 years, most of the tumors would be hematolymphoid malignancies. That means leukemias and lymphomas. And in the younger age groups, it would be mostly leukemias. And as you grow slightly older, it slightly tilts towards the lymphomas. Now, as the child grows more, slightly higher ages of 10 to 14 years to 15 years, you start seeing the CNS tumors. And beyond that, you would start seeing the sarcomas. And the slightly older children would see, you would end up seeing the epithelial tumors. And some of them is like the nasopharyngeal carcinomas that you see in Indonesia. So that's important to remember the kind of tumors that you will see, because when you develop a radiotherapy facility or a pediatric radiotherapy facility, you need to remember what kind of patients and what age of patients that you would be dealing with. Now, are these distributions, are the patterns different in the Asian region compared to the West? The proportions are not. In the West, the numbers would be slightly higher. If we are seeing about 110 in Asia, in Indonesia, you would probably see slightly more in the United States and Europe. But the proportions of kind of tumors that you see still remains the same across the globe. Now, since I was asked to talk about specifically about radiotherapy in children and its global implications and how you would develop, we need to see where we use radiotherapy in these children. Now, we know that a large proportion of these children who develop cancers would be coming from the low and middle income countries and from this part of the world. It is important that we have protocols that are adapted to our situations. So in this table, I'm just showing you a list of tumors that we see in children. And on the right-hand side of your screen, you can see what proportion of these patients would actually end up receiving radiation therapy. And this will help us understand what is the burden of patients that you would be requiring, in whom you will be requiring radiation therapy in children. Now, this is a common tumor that you see in your part of the world and our part of the world here. That's nasopharyngeal carcinomas. Here, almost all these patients, all these children would require radiation therapy as part of the multimodality treatment. Similarly, for these bone tumors and soft tissue tumors, like Ewing sarcomas, almost 40 to 50% of them would receive radiation therapy as part of their treatment protocol. Similar thing you would see in rhabdomyosarcoma, and most of the non-round cell soft tissue sarcomas that are of intermediate and high risk would end up receiving radiation therapy. CNS tumors, a large proportion of the solid tumors is formed by the CNS tumors, and majority of them would require radiation therapy as part of the treatment. For tumors like the Wilms tumor, in Wilms tumor, gradually the trend has been to try and reduce the use of radiation therapy, especially in the favorable risk group, but still a significant proportion of these children would require radiation. For retinoblastomas, the role of radiation in early retinoblastoma is going down, but still for advanced retinoblastomas and for retinoblastomas not responding to focal therapy and chemotherapy would require radiation. Similarly, for neuroblastoma, the role is little, but still for high-risk neuroblastomas, all children would require radiation. For Hodgkin's lymphoma, the outcomes are very good, so the efforts has been to try and reduce the use of radiation therapy in children so that the long-term side effects of radiation and the combination of radiation and chemotherapy is reduced. In CNS, currently the new protocols that have been developed use very little radiation except for patients who are CNS positive or are high risk of disease. And finally, for palliation, radiation therapy in children is extremely, extremely effective. So to put it in a nutshell, radiation is still required in majority of the solid tumors and a significant proportion of the hematolymphoid malignancies in children. Now, coming to the basic principles of radiotherapy in children, the broad principles remain the same like we see in adults. The primary aim is to deliver the optimal dose of radiation to the tumor and spare the surrounding normal tissues so that the disease is controlled and the side effects are minimized as far as possible. So what is so important in children when you're using radiation? We know the side effects of radiation in children, and for that reason, it is important that we use radiation only when the indication is completely proven, or at least that there is some indication that there is use of radiation therapy in improving disease control. It is extremely important to sequence and treat in a multimodality regime. It is important to sequence the radiation accurately and appropriately with chemotherapy and surgery, and the timing should be appropriate. The doses of radiation should be optimal. They should not be very high, and the target volumes have to be very accurately defined, again, because of the associated toxicity of RT. We should minimize the dose to normal tissues, more important than in the adults, And the importance of optimal technologies and techniques is extremely important in children. So in a way, and of course, finally, you have to have the right infrastructure for treatment of pediatric tumors with radiation. And there's a big role to do with supportive care and rehabilitation. So in a way, what I'm hinting is for treatment of pediatric tumors and the use of pediatric radiation oncology, it should be only in specialized centers that have enough experience and infrastructure to deal with such tumors and such children. Over the years, we have better understood the natural history of these tumors. We have better imaging techniques, better target delineation. We have understood better ways of sequencing chemotherapy, surgery, and radiation therapy in a multimodality approach. We are very conscious about acute and late effects of radiation therapy. And now we have wonderful tools in radiation therapy to use in order to control disease and reduce the side effects to as less as possible. So this is a slide just to show you the simple cobalt machine that was also used once upon a time. But I think we have moved to an era now where we should move on from simple APPA techniques and non-conformal techniques to complex conformal techniques using all these different kinds of teletherapy machines that is available to us nowadays as radiation oncologists. And this is extremely important, especially when you're talking about pediatric radiation oncology, where you're concerned about late effects. Brachytherapy, we have been using for decades now, and it is one way of reducing the side effects of treatment by reducing the normal tissue toxicity. So brachytherapy, again, plays a very important role in the treatment of pediatric tumors. So I'll just take a few examples to highlight what is the importance of these things: multimodality approach, conformal techniques, rehabilitation, and supportive care. Nasopharynx, the standard treatment is chemotherapy and radiation, and we need to deliver high doses of radiation therapy in order to achieve disease control. But the problem in these children is that it is located very close to critical structures like the eye, the brainstem, the parotid glands, the bones, the temporal lobes here. So it can have a significant toxicity effect in the long run if you are not very careful. And these are the lists of various long-term toxicities that can happen with high doses of radiation like this. So it is absolutely important that we move from 2D radiotherapy techniques in children to 3D conformal or intensity modulated radiation therapy in order to achieve good disease control and reduce toxicity. And these are available now. And this is very important that we move from the 2D techniques in children to 3D conformal and IMRT for obvious reasons of being able to reduce the side effects of radiation in the normal structures. This is especially important in sparing the normal tissues like the parotid, the bone growth, the muscle growth, and there's an hypoplasia and fibrosis of tissues that we see with conventional radiation therapy. Now we looked at our own experience of using conventional versus IMRT. You don't have to look at the details. The disease control is extremely good, but what we see importantly is that by using IMRT, we can significantly reduce the acute and late toxicities of radiation therapy in these children with nasopharyngeal carcinoma. With better techniques like proton beam therapy that is available now, as you can see from this slide, very nicely you can spare the normal structures, and there is a significant reduction in the spillage of radiation that happens even with intensity modulated photon therapies. So these are the techniques that should be kept in mind when you're talking about pediatric radiation oncology. So I used nasopharynx to show how important it is to do a combined modality approach and to use good technology in order to get good outcomes. The other example in children is Ewing sarcoma. Now, Ewing sarcoma is seen in relatively young children, about 14 to 15 years of age. Majority of them would have tumors in the pelvis and the centroaxial skeleton. And in them, radiation therapy once upon a time used to be very effective. and the local controls were extremely good with radiation therapy. But the problem was that many of them would fail distally, and that is how chemotherapy and radiation therapy, the combined modality approach, came in Ewing sarcoma. The other thing is that currently, local therapy, we are not very sure about which is the most optimal form of local therapy, surgery versus surgery and radiation therapy. And I have listed out various indications of radiation therapy in Ewing sarcomas after induction chemo, for inoperable tumors, for expected surgical morbidity, and for tumors where the surgery has been done intralesional. For post-operative cases with poor necrosis, with fractures, with large soft tissue component, there has been benefit of adding adjuvant radiation therapy. So this actually highlights the importance of, again, combined modality treatment in the form of chemo, radiation, and surgery. And the combination of all three actually results in the best outcome compared to radiation alone or surgery alone. Quickly moving on to a little bit of brachytherapy. In children, brachytherapy is a very useful tool, and it is again extremely useful in reducing toxicity in children. This is an example of a soft tissue tumor in the leg, and external radiation would have involved a lot of the bone, leading to bone hypoplasia and growth defects later on. But with brachy, you can actually spare those side effects to an extent. As you can see in this example, this child has hardly any side effects of treatment. So the other modality I'm trying to show here, which is very useful in children and pediatric radiation, is interstitial brachytherapy. And this slide actually tells you how effective it is. 10-year local controls of 83% is extremely good local controls, and we hardly see any side effects of these treatment. So that is another example of trying to use the right technique of radiotherapy and the right technology of radiation therapy, and the need to have the expertise in those fields in order to have a very good pediatric radiation oncology facility. Collaboration with your colleagues in surgery and having a multidisciplinary unit is extremely important. Now, this child had a botryoid rhabdomyosarcoma, gave chemotherapy and had a very good response to chemo. Now, this patient would obviously require radiation, and the cure rates are extremely good, but we need to ensure that we preserve fertility in these young kids. Also, this kid, because we had a discussion in our multidisciplinary clinic, we knew that this child would require radiation, so we put these ovaries outside. We did an ovarian transposition. So all patients, in a way, I'm trying to highlight that all patients in a pediatric oncology unit should be discussed in a multidisciplinary joint clinic in order to define how you would want to treat this patient, and that would end up in the best outcomes. So this is the radiotherapy plan, and we were actually able to spare the ovaries very well from the radiation dose. Just to touch upon a little bit of Hodgkin's lymphoma, radiotherapy is very useful in treatment of Hodgkin's lymphoma. It's very effective, but it is associated with good long-term disease control, but associated with late effects like cardiac late effects, thyroid toxicity, bone soft tissue toxicities. So now the approach has changed from there to, again, a combined modality approach and a risk and response adapted approach. And what the Europeans are doing now, and also the Americans, is that you are going for a response adapted approach. Why am I showing you this slide? I'm showing you this slide because it is most ideal to discuss with your medical oncologist before we start the treatment, so that you have a plan in mind and you just optimize your treatment in a way that you don't unnecessarily cause long-term toxicities. This is the American approach, again, trying to use radiation only in patients who actually require radiation therapy. So over a period of time, the radiation portals have also changed from large fields like total nodal radiation like this to involve nodal radiation and involved site radiation therapy, which are smaller and causes less toxicity. Other techniques have also come in where you can actually use newer methods of delivering radiation, where the side effects can be reduced. And this is again very important in children and especially in girls, where you would try to avoid the breast being radiated and avoid long-term toxicities. So we looked at, we did a study in 2009 looking at from the IAEA to look at what were the problems in Asia regarding pediatric radiation therapy and delivering optimal pediatric radiation therapy. So few of the things that came was pretty common, and it was similar to what we saw in the West. General lack of knowledge regarding childhood cancers, malnutrition, differences in the biology, a lack of trained personnel and pediatric radiation oncology. That's again very important. Infrastructure is very important in the form of good radiation machines, brachytherapy, anesthesia. So these were the main things that came common between what we saw in the West and in this region. So if we are planning for a pediatric radiation therapy facility, we need to keep all these things in mind. We have to have a comprehensive. This was a thing from the PROS, the Pediatric Radiation Oncology Society. Again, they were also looking at how we could improve the quality of pediatric radiation across the globe. And so PROS was founded in 2006, and I happen to be one of the founding members of PROS. But the mission was very clear: to spread the skills and competencies in pediatric radiation oncology globally, to have a worldwide standard of care for pediatric radiation oncology, to have a forum for communication like we are doing today. That is extremely important, to have a forum of communication through meetings, through correspondences. We need to have projects because we come from similar backgrounds, so we can have outcome projects also. And also, if required, to develop guidelines that suit you in the Asian and the Southeast Asian region. This is another thing that came from the European group. They are also trying to streamline their pediatric radiation oncology facilities in a way to standardize the quality of pediatric radiation oncology across Europe. And this was through SIOP, ESTRO, PROS, and the CCI. And what were they looking at? They were looking at whether you have a tumor board or not. That's why I said multidisciplinary clinic. Whether you do consultation in the radiotherapy clinic, and do you explain regarding what you're going to do, how you're going to do, what are the side effects? Do you do a treatment plan QA? So that is again a very standard thing that is required. And then, of course, the equipment that is available for you, MRI, PET scan, CT scan, and the LINACs, and the proton therapy machines, and brachytherapy. So they were classifying groups into various categories based on what is the kind of infrastructure that you have. So in pediatric radiation, it is extremely important to have all these facilities. So just to sum up what are the essential components that you have to have if you want to have a pediatric radiation oncology facility. You have to have obviously a radiation oncologist who is aware of how to use radiation in children, a medical oncologist or a pediatric medical oncologist, surgical oncologist, pathologist, radiologist, pediatric nurse, clinical psychologist, rehab services, long-term follow-up clinics, and pediatric palliative care. Now, these people are essential part of the pediatric oncology unit. Besides that, in terms of infrastructure, what do you want? It is pretty similar to what you want in adult, except that you have to have an anesthesia facility also, because many of these children will require anesthesia for treatment. You have to have treatment guidelines, very standardized, and you need to follow them regularly over a period of time to see that you settle down to a particular guideline and can see outcomes. The clinics should be multidisciplinary. It should not be a one-sided decision that you are taken. And the need for support groups, fundraising, and awareness is extremely, extremely important. What about educational courses and practical teaching? It is extremely important to have educational courses and practical teaching. And this is a wonderful course that I attended, and thanks to, again, Prof. Tati and the wonderful group at Cipto. These are the kind of educational courses that you need to have. And it is, again, very important to have these courses in the region rather than going and attending. It is nice to attend an astro course or an astro course or a pros course, but mind you, the milieu in which you are doing these is different. The backgrounds are different. So it is important to see that you do these courses in the region where you have the same kind of background, same kind of economic factors that influence, and the same kind of diseases that you see. So just to end up my talk, it is not only the treatment part. The financial support is required, accommodation, blood transfusion, nutrition, psychological support, education, entertainment, schooling, continuation of school. Everything is so important in finally having a good, comprehensive pediatric cancer unit. So although I focused a little bit on radiation, but in pediatric oncology, the radiation or chemotherapy will not go alone. It goes as a multidisciplinary team, and it is a combined thing that you need to have in order to have the best outcomes in pediatric tumors. So thank you very much. I know I overshot the time a little bit, but I thought I should tell you as much as possible. So thank you.
Thank you. Thank you, Prof. Siddharta, for your excellent talk. So now we will come to the questions and answers sessions. Okay. Before that, I also would like to inform that we have here also as panelists, Professor Miriam Calaguas from Philippines. Hello, Dr. Miriam. Yeah, and also Prof. I from Myanmar, but I think she has already left. And also we have here Prof. Ivan Tom from Singapore. So we have here some questions. Okay. So I think for the first questions from Dr. Ludi. Dr. Ludi is a Pediatric Hematology Oncology Fellow from Cipto Mangunkusumo. She would like to ask about the burden in Indonesia regarding the medications, chemo, drug prescriptions, access compared with other countries in Asia or internationally. What is your thought or proposed solutions about that, and how to maintain its sustainability and availability? Dr. Gampo, would you like to answer these questions? Thank you.
Thank you. So thank you for the question, but rather I would, if some of the panel members would like to address, I'll be very happy, because I think some of the solutions have come when Dr. Endang and even when Professor Siddharta mentioned about that. So I think that's there. Can I request some of the panel members, such as the newer professors, to respond if they want? Yeah. I'm okay to respond, but I really want maybe others to respond on this, if there is any.
I think the question from Rudy is it's occur in our hospital Cipto. The sustainable of the chemotherapy sometimes unavailable. That's the problem. So the question of the Rudy is very important. I hope that the Gampo can get one of the target that we have. Should we have an excellent center? I think that's the problem.
Can I answer?
Yes,
please, Prof. Tati.
Yeah, I think it depends on the plan that we have. Also in radiotherapy, when I start to work with the radiotherapy, we have a lack of equipment in our countries, but we have to have a real planning program, and we have to talk with the decision maker, like with the P2JK and with the BPJS, and I mean that's a kind of struggle, fighting that we have to do, and I mean because each countries have their own problem, and they have their own solution. Somebody have to do it. We have in our society, for example, we have a roadmap. Anyhow, we have to sit together. And then we have to face the problem. That problem is not the problem from the WHO, not the problem from the Siddharta, Professor Siddharta. It is our own problem. I think that's my opinion.
Yeah. I got your message, but we are lucky that the non-government organization help for make it easy to get the drugs. So now we work on that. Now we do understand about the government problem now, but we hope that the availability, the sensitivity is it. But we try to go by other course.
And maybe you can try also to work with the donation.
Yeah.
There are a lot.
We do that. Yes,
That's
we have a lot of NGO interested in the childhood cancer. Thank you for that.
If I can add, Gisel.
Okay.
Yes.
You may have. Yes. You may.
So like Prof. Tati mentioned, that we can have guidelines from people. We have but what we have to do is on our own, and only then it will be sustainable, because there's a limit to which the government can support you. And I can tell you that from our own experience, in our pediatric oncology unit, there will be no child who will not be receiving a treatment because they don't have money. And most of the money here would come from donations, philanthropy, and funding like that. So although we have government support, but majority of the support for these kids would come from donations. And a typical example is St. Jude Children's Hospital in Memphis. They raise almost about $1 billion a year on donations.
Yeah, I agree with you, Professor.
Thank you, Prof. Sid, for the ideas. I remember you have said that when you came here.
Giselle, Dr.
Yeah, Prof.
Miriam, Dr. Miriam is available if you want to ask her to give her comment the situation of pediatric oncology in the Philippines.
Yes, Prof. Miriam Kalaguas, I think you have heard. Maybe you can have some comments or suggestions for the matter. Please.
Oh, good afternoon, everyone. It's really a pleasure to be part of the webinar. I just intended to listen. I didn't know that I was going to speak, but it's nice to see, of course, my dear friend, Professor Tati, and Giselle always, and Maya. These are my friends there in Jakarta. Of course, Dr. Laskar. We have been seeing each other in so many meetings in IAEA, Astro, and PROS, of course. And Dr. Endang, I enjoyed your lecture very much for the overview, and Dr. Gampo. So this is a very well-organized webinar in pediatric, and many of my residents from the Philippines are listening right now. I encourage them because I think it's a very important subject in radiation oncology. So yes, we believe in the multidisciplinary approach to treatment. We have the surgeons, the medical oncologists, and the radiation oncologists, of course. And thank you for that overview, Dr. Laskar. And we don't have a proton beam. So my question is, I've been to India and I saw the proton beam in Chennai, your very first. So how do you see proton beam coming up in the next few years as an important treatment modality especially for pediatric patients? Do you think that there will be more countries that will be putting up and with much more advantage over the present day linear accelerators?
Yes. So there are 70 centers across the globe now with proton beams, but and majority of them use protons for children. And we have seen that protons have helped, although not in randomized fashion, to show that the toxicities of treatment can be reduced with protons. And I can see a increasing role of proton therapy in children. In India, we have one functioning, and our center, I'm actually leading the proton therapy center in TMC. And we have just done our beam on degrader. And hopefully by May next year, we would be treating our first patient. So, and obviously we will be treating a lot of children. So the cost is a problem, but in our center, obviously we'll be treating 50% of our patients completely free of cost. So that's our thing. So if we are treating 800, we expect to treat about 800 patients a year, and 400 to 500 we plan to treat free of cost completely. So, and many would be children. Of course, my interest is children. So
maybe you can, so we can also send our patients there, as you were talking about networking, yeah,
yes,
within the region. I
yes,
think this would be much well, cheaper compared to sending our children to America or Europe.
yes.
Or, yeah, I think I'm very happy that we have it there, accessible to Asian children for treatment
Yes.
in India.
Definitely, definitely. They will be given the highest preference coming from you. Yes, definitely.
Thank you, Prof. Miriam, Prof. Sid, for your comments. And we will move to the next questions. Next questions from Professor Jayadiman Gatot. He's asking to Dr. Endang. Dr. Endang, based on your presentations, how many centers of pediatric oncology properly needed in Indonesia, with many islands, with huge populations, which are not equally distributed? Congratulations for your presentations, he said. Dr. Endang, please.
Oh, Jayadiman is my teacher. It should be answered by him. Okay, so ideally, every capital of the province have a center for childhood cancer. So now, like Papua in the east one was the large island, is not have any. In the Sulawesi, only 2 centers. So it should be, ideally, is every province. But we have to think it's not easy to go there. So I think we have to think about the referral system. Like in the Papua, it should be to Makassar, but the patient directly to Jakarta, something like that. So we have to think also the referral system make them easy. Maybe they don't know that Makassar already have the pediatric oncologists. Like in the Bali, we have 2, and the NTT and NTB is going to Bali. So that's what we want to. But if asking how many, of course we have 30 provinces. It should be there, I think, because a lot of, I'm sure that a lot of pediatric patient is still undiagnosed because they don't have access to go to medical center. I think that's my question and my answer for Prof. Jaya question. Thank you.
Thank you, Dr. Endang. And next, we have questions from Arifianto. There are many children with brain tumor who were diagnosed late and should either have surgery or radiotherapy, but due to the limitations of radiotherapy center facilities and neurosurgeons, the prognosis became worse. As long as there's no problem solving involving government's will and coordination leadership, there will be no improvement in fixing the problem. The question is, should all children with brain tumor undergo radiotherapy if the neurosurgeon is unable to remove the mass completely? So anybody would like to answer that question?
I think I have already answered writtenly about the question about the distribution of the radiotherapy. It is clear in my presentation. We have 58 center of radiotherapy all over of Indonesia, and it will become next year. Maybe it will become 67. And actually, the rate of the brain tumor patient, pediatric patient who come for the treatment, there are many reasons, not only because of the radiotherapy or because of, there are some other reasons. And one of the reasons is the awareness of the parents, awareness of the doctors, and such a kind of things. And nowadays, we can also give the chemotherapy for the patient with the brain tumor, even for the pediatric, like temozolomide. We can give also the temozolomide for the patient. And that's it. And for Dr. Endang, as I mentioned, I don't know for the pediatric oncology, but for the radiation oncology, maybe also Professor Siddharta and Miriam, now we can do calculation exactly within the country, how many doctors, radiation oncologists that we need, how many equipment that we need. So we have, we can make like a roadmap proposal and bring the map to the government, and then make some like leveling step every 5 years. What can we do? What is achievement that we want? What is the target that we want to achieve? I think such a kind, but we have to have a good data. If I'm not mistaken, there are, in my data is 58, but you mentioned maybe it is a newest data, you have 61.
61 now, yes.
Pediatric oncologists all over. That's the one thing, we have to go to the government to let them know about the situation. And the second is, we know that there is 14 national referral hospital. Now, if the 14 national referral hospital is already equipped with the pediatric oncologist, the human resource, as well as maybe it can, so the referral system can be better.
Yeah,
so
yeah.
use the national referral hospital, even there is also. So for the others, just for information, we use the so-called the national referral hospital. We have 3 levels of the hospital, type A, type B, and type C. So with that situation, because our countries is very big with 17,000 islands with more than 250 million population. So it should be well managed with the referral system. I think that's why the question from the doctor in the Q&A, I was asking where is he? I just want to know if he is, for example, in NTB, they can go to Lombok, or when he is in Sulawesi, he can go to the either to Manado.
Manado and Makassar. Yeah.
So
yeah.
That kind of situation.
Yeah. Thank you, Prof. Tati.
Thank you, Prof. Tati, for adding the answers. And also, Prof. Tati, there's questions about the status of brachytherapy for pediatric cancer in the hospital, in our hospital. Actually,
we have a brachytherapy, and but almost we never use the You're right, Professor Jayadiman. We almost never use the brachytherapy for the pediatric cancer, but it doesn't mean that we cannot do it. Of course, we can do it. For example, the interstitial brachytherapy, for example, for the soft tissue sarcoma, we can do it. But we never, until now, we never have a possibility to do it. Never send the patient to us. But maybe we can ask to Professor Siddharta Laskar about how is your experience using the brachytherapy in the pediatric oncology.
Thank you, Prof. Tati. That is the topic that I love the most. And
I know, that's why I sent it to you.
Pull me into that, then I will speak only about it. So yeah, to put it in one word, brachy, I think, is an extremely useful thing in children. Brachy treats a very small volume of tissue. And fortunately, in children, that volume of tissue that you need to treat is again small. And in children, it is even more critical to spare normal structures. So by doing brachytherapy, you can wonderfully spare normal tissue. And if you're doing radical brachytherapy, you can avoid the requirement for the child to come to the hospital for so many days of fractionated treatment. So brachy is extremely useful in terms of disease control, extremely useful in terms of reducing toxicity. The only difficult thing is to get a wonderful team together. And I'm sure with your charisma and charm, you will easily get a team together of a surgeon, medical oncologist, radiation oncologist who's interested in brachytherapy. And I think it gives wonderful results. You can have a look at my 10 years outcome data. It is 83% at 10 years. And what else do you want? No complications. So when I speak to my friend Arnold Polino, I tell him this is poor man's proton therapy. So
what kind of cancer and what kind of brachytherapy? Interstitial? Not mostly.
So for all the soft tissue sarcomas, we evaluate for all soft tissue sarcomas, which includes PNETs, non-round cell soft tissue sarcoma, rhabdomyosarcoma, for all sites, for all locations. It is extremely useful. It is difficult, but there are good people with you whom you can train and they can do. I don't mind coming once a month and training you.
Okay. So our pediatrician can hear that we can
start, Prof. Tati. We can start there.
We can share our modality also for the, for the soft tissue sarcoma, for the
rhabdomyosarcoma.
brachytherapy.
May I say something? May I say something?
Okay.
Yes.
Yeah. Well, Professor Tati, you can start a regional training course on brachytherapy for pediatric patients. And you can have it there, and you can invite us, and we can attend with Professor Laskar, and maybe our friend also, Dr. Paulino, to guide us. So maybe for SEARO or even for FARO.
Yes.
Yeah. It's very interesting. It has not been taken up in IAEA before. And now we have an expert here who will be willing to teach us. I like that, the poor man's proton beam, because I don't see the region, like us here, we will not be having a proton beam for so many years to come.
I find that more exciting than proton.
Yes.
Yeah.
From the cost, for sure, from the cost.
Yes.
The cost of brachy is much lower than proton.
Yes, lower.
Okay, we still have questions. So this is questions from Triani Martio. The questions is quite long, but I think she would like to ask for advice about what we should or how we should educate or told the patient to start the treatment earlier, because there's so many delay. I think that's the point of the question. So anybody would like to answer that questions?
What is the question?
I would like to ask for advice about what we should educate or told the patient to start the treatment earlier, because as we see, leukemia is highest in childhood cancer epidemiology, but the delay is quite often. I think that's the point of the questions. Delay treatment and how to educate the patients to ask them to want to start treatment earlier.
Okay, I think I can answer that. In my experience, even the doctor, the nurse, try to, how important is treatment early, but the important thing is the parent of the survivor or the parent of the patient still in the chemotherapy. Talk each other, parents to parent, and it's a very strong suggestion. And then that's a very good one for the education. So sometimes Like in our hospital, we have an educator on the survivor osteosarcoma. Now, if there is a new patient of osteosarcoma, this girl is already adolescent, come to us, then talking about that I'm also, and I'm survived. That's a very, I think, bahasa Indonesianya ampuh is a very good one for the education, not doctor, not nurses, but the survivor can use for educators, a good educator. We have one, and also other like in the ward. Sometimes in the first time, the children come in the ward for the chemotherapy, then the father still reject for that, then the parents talking each other. My child also like that and something like that. So I think not only doctors and also the parents, the club of the parents, we have that for education. That is a very good one. I think that's. Prof. Tati, have a other opinion about that?
Yeah, that you're right. There are a group of I know that there are a group of I just
Survivor, the parents.
I just write the answer to Ibu Ira. Ibu Ira is here. Ibu Ira is one. Ibu Ira is here. There is also Ibu Rahmi is here. There are some of the very good parents community that eager to help us. It is also like in other adult cancer. For example, in our department, every week they come, the survivors to our patient come and sit with the patient and make them happy, and so they make some events, singing together, and improve the psychological. So the survivor or the parents community is a very strong. I mean, very strong. I mean, can make a lot to improve the psychological condition of the patient and the parents. I think that's a good idea to use the survivors group. Maybe we can ask the comment from the parents group. I know that here there's some parents group. To the host, can you open? There is Ibu Rahmi, there is Ibu Ira, there is also maybe some others here.
Giselle, can I?
Giselle?
Yeah. Okay. We are working on. Prof. Sid, do you want to add something while we are waiting?
One quick suggestion. Most of the delay that happens in children coming to the hospital is when they are loitering around and meeting doctors in a non-specialized area. So what in India we are trying to do is we are trying to educate general practitioners and tell them what are the signs and symptoms of pediatric tumors like leukemias, say for example. Sometimes some people give steroids and things like that and then ruin everything and then they send to you. So we have a national training program where our pediatricians actually tell GPs and people like that, because the first contact for children and parents is with general practitioners. So if they delay, then the entire thing gets delayed. So if you can tap the resource of GPs, you will be able to get them referred to a specialized center like yours very soon.
Thank you, Prof. Sid. Yeah, we have already have here Mrs. Ira Sulistyo, one of parents survivors.
Parents community.
Yeah, from child.
Yes, good afternoon, everyone.
Hello.
Hello. Yeah.
Hello.
Good afternoon, everyone. Thank you for the opportunity for me.
Yes, Bu Ira,
you
can talk.
Yes, I have a question that about just to follow up on what he has mentioned, that we can follow up with the MD from the same regions. is there any also possibility that we can do it by teleconsultations? Because, well, Indonesia is quite a big country and we are separated by many islands, so it would not be that easy. Well, not to mention also internet system, the facility, not many people have that, but yet that is, I think, the best way to communicate, because most of them during this pandemic, they cannot go from one place to another. So this is another thing that we are facing for the abandonment. And to prevent that, we need, maybe you can share us your experience how to overcome this, either by teleconsultation or consulting with the doctor himself, I mean the pediatric oncologist. Because, well, to tell you frankly, I mean, based on our experience, sometimes even the MD also have doubt to give any advice to childhood cancer patients. That's another thing that we are facing. So how do you overcome on that? I mean, not many MD can understand also about childhood cancer, especially patient who has already in treatment. Can you comment on that? Anybody? Anyone? Hello. Yeah.
Yes. Actually, for our patient, the patient who are, maybe it can be also used for the patient under other modalities. In our patient in radiotherapy services, so we have a flyer for the patient. If they in the flyer there are some mention, but one of the statement is if they have some complaint or something that they want to ask the doctor regarding to the COVID pandemic time, so they can come to the medical facilities, the nearest medical facilities. They can come and they can contact us. Usually we give our number that can be contacted. And also, Bu Ira, is a very good idea. We already do it, the teleconsultation. So we do a lot the teleconsultation with the patient when they need to ask something to us. So that's, I mean, that's a good idea about the teleconsultation. But also we can do is, for example, when the patient cannot come due to some another reason, as I mentioned, they can come to the nearest medical facilities, and then the medical facilities can contact us. So there are some other strategy that we can do to close the distance between the patient and the doctors.
Yeah, thank you.
Thank you, Prof.
Yeah.
Thank you.
Since we have already managed several houses in all over the country, so it is really a problem. In some centers, they can accept those kind of teleconsultations, but in some hospitals, they are not accepting that. So what they suggest is they still need the patients to come to our shelter, but they have to pass so many tests, but even to be quarantined. So that's another problem or another thing that we have to provide so far with all the shelters, that we will provide rooms also for the quarantine for the patients before they go to the hospital as well, or when they return from the hospital to our shelter. This is very difficult for us to work with, you know, because at the same time we are also accommodating, I mean, patients, they are already staying from the start before the pandemic. But on the other hand, we have also to accommodate or facilitate this who are coming from their hometown, you know, so this kind of really make us a burden. And some centers was also mentioned that there is no legal regulations to do these teleconsultations. So perhaps the other country can share us, how do you overcome on this matter, you know, doing the teleconsultation, and how far we can do by teleconsultation and etc.
maybe before the answer from the other abroad, actually there is already a decree about the teleconsultation from our, what is ED, Giselle?
From the KKI Council, I think.
As well as from there are 3 decree allowed the teleconsultation, especially in the time of pandemic, COVID pandemic. One is from the council, one is from the Ministry of Health, and the other is from the
Medical Association, Indonesian Medical Association.
Indonesian Medical Association. So actually, Bu Ira, if you need it, we can send you by WhatsApp the decree about the teleconsultation right now.
Okay, thank you so much. Yes.
So thank you for sharing with us, Mrs. Ira. I think this has been a very exciting topic and discussions, but unfortunately we have already reached the end of our webinar because it's already 7 minutes past 3 p.m. here. So I would like to thank you all, to all of our speakers.
Excuse me, can I ask one more question to Dr. Endang?
Okay. Is there any time?
Okay.
Or you can privately ask me.
Yeah, it's about that you mentioned that only ALL or leukemia has the same protocol all over Indonesia.
AML and ALL, we have the national protocol.
So how do you plan to move faster to have other childhood cancer to become also the same protocol, you know, because it's been quite some time and we are now actually have mostly 8 types of cancer. So what is your plan? Is there any plan? Or...
Acute leukemia, only the pediatrician involved treat the patient. But for the retinoblastoma, other oncologists from the eye, and then also radio treatment, radiotherapy, and also the pathologist, it should be come. We try to do fast, but it's not easy to collect all the specialists involved in solid tumor. But don't worry, we already have a team for the retinoblastoma make for the national protocol. Because not only pediatrician, there are other department specialists that handle the retinoblastoma. So coming soon, we have already team that.
Okay, look forward to it. Thank you so much.
Yes, welcome.
Okay, thank you. So again, thank you for sharing all with us. This has been the end sessions of this webinar. I would like to thank you to all the speakers, Prof. Siddharta Laskar, Dr. Gampo Dorji, Dr. Endang, and also the president of Iros who made these webinars come true, Prof. Soehartati Gondhowiardjo, and we also have here joining with us, Prof. Miriam Calagues from St. Luke Hospital, Philippines. Thank you for joining with us. I think Dr. Lisdina, our President Director, has already left, and also previously we have Professor I from Myanmar, and also actually there's Dr. Ivan Tam, I think he has already left. So thank you all. We would like to meet you again, maybe next in the brachytherapy course. Okay. Yeah. Thank you very much, everybody. For all participants, you can help us to improve these webinars by filling out our questionnaires. You will have the link on the chat. So your feedback is very valuable for us. And so you can also re-access the recording of this webinar on our YouTube channel, Iros YouTube. Okay, so this is the end of the sessions. Thank you, everybody. Bye-bye.
Bye-bye. Thank you.
Bye.
Bye. Bye-bye.
Bye.
Thank you, everyone.
Bye, Tati. Bye, Giselle.
Bye,
Bye,
Dr.
Dr. Indang.